Well, we're going to go on to testosterone replacement therapy, and we've alluded to some of it. Also, tomorrow afternoon, the last lecture that I call Nuts and Bolts, I will go over again the dosing, the practical aspects of here's the compounded preparation, here's the ways you can prescribe it, here's the controversies, here's the devices that dispense it. And so the purpose of that Nuts and Bolts presentation is because that will give you the practical ways to actually prescribe these compounded hormones, Monday morning, as we like to say. So one of the paradigm shifts in anti-aging medicine is that one of the causes of aging is hormone decline. It's not the other way around, that, oh, well, you're getting older, of course your hormones are low. And testosterone replacement therapy is safe, and benefits can be quite dramatic. Again, I'm always looking for the inflammation connection, and testosterone decreases inflammation. So there's a lot of names for male menopause, or androgen deficiency aging male, or it's not sudden in onset like female menopause, but just as severe, and the problem is decreased bioavailable testosterone. It's absolutely amazing that you still see discussions in endocrine publications that there's no such thing as male menopause or ADAM or etc. Ask any man who's been there. So it's not just sex and muscle. There's increased aging of the heart and circulation, decreased testosterone, more MIs, CVAs, increased brain aging from just mild cognitive impairments to increased Alzheimer's and other causes of dementia. And then there's the loss of drive and competitive edge. The general inflammatory state, stiffness in muscles and joints, when the only thing stiff in the morning is your back, could be male menopause. Falling levels of fitness despite trying hard. If you don't have the anabolic hormones, you just can't build muscle. And so workouts are not as effective. If cardiovascular disease or cancer doesn't get you, sarcopenia, frailty, less muscle, more fat, more fractures, etc. Low testosterone associated with osteoporosis in men and anemia. Also, low testosterone is associated with increased prostate cancer and all cancers. There's the general fatigue and grouchiness and irritability and dysphoria. Libido's decreased, and erectile dysfunction is a continuous spectrum, so it's not an all or none, but decreased erectile tension, a longer refractory period between orgasms, and decreased intensity of orgasms. So the concept here is we're not just throwing hormones at people. We diagnose a deficiency disease and treat it. So how do you define it? Kornman's analysis here. If you take healthy, quote-unquote, men between 50 and 7 and look at their bioavailable testosterone, we'll talk about the different measurements. If you took that same number, for a 20-year-old, he would be sick. That would be pathological. So why wouldn't we have the same standard of wellness and quality of life for everyone? That's where we get into the concept, once again, of not just normal for age or reference range, but optimal range. Testosterone decline starts early, and between 25 and 75, the most important number is here, there's a 50% decrease in bioavailable testosterone. And worldwide, testosterone is getting lower every year. So it's getting lower in an individual, but it's getting lower worldwide. And you can pick your own environmental toxicity theory for this. So let's take a look at, say, a 60-year-old. In the 80s, average total testosterone was like 550 or something like that. In the 90s, 490. In the early 2000s, like 420 or 30. I don't know. We could assume the curves are going to keep going down. So as I said, pick your theory, but this is like one of the disaster movie scenarios. There won't be any testosterone. So andropause is a lethal disease because it's associated with insulin resistance, metabolic syndrome, cognitive dysfunction, cardiovascular disease, frailty, inflammation, and all cancers. Now, there have been quite a few studies looking at endogenous testosterone over the past few years. A criticism could be, well, this is endogenous. This doesn't tell us about treatment. but I think we can still gain a lot of information. And I referred to the CAW study in Circulation a couple of years ago. Now, I think this is important, first, because it's in Circulation, and it's certainly a major journal. And so if your cardiology colleague says, oh, well, testosterone's got to be dangerous for the heart, you heard that somewhere, you could, if you want to be obnoxious like me, you could come back, don't you read your own journals? What about that article in Circulation? No, you shouldn't do that. And the article in Circulation looked at 11,000 men, and again, the higher the testosterone, the lower the mortality from cardiovascular disease and all cancers. And on the subsequent slides, which are in your handout, there's a further analysis. Again, comparing a testosterone of 300 to 1,000, there's a 57% decrease in the chance of dying in the guy who's got 1,000. So where would you rather be? What about adverse effects? Now, again, to look at the whole literature, see, don't want to quote cherry pick articles that kind of support what I believe, but let's see, are there any negative studies? And there is this curious Spessaria study in the New England Journal in 2010. And the concept is adverse effects, cardiovascular effects in men who were treated with testosterone. So these were older men with decreased mobility, various chronic diseases. And they defined that testosterone gel treatment had more cardiovascular events. But they defined, in my analysis, they defined cardiovascular events very loosely, such as peripheral edema. Interestingly, estradiol was not reported. And one second, and it was a small study. So I don't put too much credence in this. An important announcement coming up.
Yes, I hate to interrupt.
Okay, go ahead.
If I don't do it now,
Okay.
Okay, we apologize for
Yeah, here we go.
overflow and lack of seating in here.
Here's an active mic.
Oh, thank you.
It has become an issue due to the popularity of these lectures. So tomorrow, these sessions will be held in Hall C from 1 to 4 p.m. Okay, so you'll have a lot more seats.
So
Thank
you mean
you.
we've made it to the big time?
Yes, you have, and I'm sorry to interrupt.
Okay, well, thanks. Okay, thanks. So, Spessaria study. Now, continue on in the medical literature. Here is a reanalysis of the Spessaria data, saying that a meta-analysis of everything else that exists does not support an unfavorable cardiovascular risk profile. Certainly, that's not been my clinical experience, and I'll show you some landmark cardiovascular studies that look at testosterone in 3 or 4 different ways to decide what's the cardiovascular situation. So first, definitions in terms of lab tests. Total testosterone. It's total. What's in the serum? The problem is it includes testosterone that's tightly bound to sex hormone binding globulin that you cannot use.